on orthopedic principles. We have Dr. Yogesh Joshi from Wrexham, United Kingdom, to enlighten us on tibial plateau fractures, current concepts. His area of interest is in knee surgery, and he does everything about the knees. Over to you, Dr. Joshi. You can share your screen.
Thank you so much for hosting this webinar. Welcome, everyone. We are going to talk about tibial plateau fractures. The emphasis on is we'll go through everything, give you an overview about what is expected from you guys, and then go in detail as to how to answer this question and simplify answering this question. I'm Mr. Yogesh Joshi. I work as a knee surgeon in Wrexham Miller Hospital. It's a beautiful part of the country. You are all welcome to come down and observe here if you want to. It's a lovely place to be. So the aim of this webinar is to go through how to describe the x-rays, how to present your case, what to look for, and understand the basis of how this fracture has happened, pathophysiology of these fractures, how the geometry of this fracture and the pattern of the fracture determines the treatment of the fracture, especially going through various approaches that you could use to treat these kind of fractures. And basically, in the last decade or so, things have changed. We are now dealing with the concepts of corridors and columns. So we'll go through that so that you have got a better understanding as to how this affects how to treat these kind of fractures. We'll also talk about how to fix these fractures and what kind of instruments and plates you can use to fix these fractures. In my territory of treatment and the patients that I see, they're quite common because quite a lot of referrals go through myself. The goal of treating these fractures to improve function, one, to improve the range of movements, and to have stable plateau so that in future, if there is a need for further treatment options, you've got a good bone base to work on. Also to know that these are devastating injuries. They can lead to very bad arthritis in the young population, and hence to treat these fractures properly in the first instance is quite important. The treatment is based on stability of the fracture. So if it's a very unstable fracture, it's best to treat it operatively to improve the stability. And stability in turn depends on the soft tissue integrity and the fracture geometry. These are axial loading injuries. They have got articular depression and comminution. So we will go through how these kind of factors determine the stability of this fracture. Also, the integrity of the fibular fracture is also important. If there is an associated fibular fracture, it indicates that the fracture is unstable. Obviously, bicondylar and high energy trauma fractures are unstable, and that determines how you treat these kind of patients. Apart from the fracture configuration and geometry, you also have to look at what the patient factors are. So if it's a very elderly patient with limited mobility, then obviously, a non-operative treatment can be offered to these kind of injuries. Going through the anatomy, obviously it's a tibio-femoral joint. The condyles of the tibia are different. So the medial tibial condyle is very different from the lateral tibial condyle. The medial tibial condyle has got dense bone in it. So when these axial injury occur, it doesn't go into depression. So they most often than not have got a shear injury without any depression. Whereas in the lateral condyle, it is much more cancellous bone with soft architecture, and hence an axial injury to the lateral tibial plateau will lead to compression and depression, and also comminution of fragments. You have to look at the attachments of the soft tissues, including the ligaments and the menisci in the knee as well. So if there is an avulsion fracture of the ACL or PCL, that will have to be addressed. The eminence fractures can be a separate entity in these kind of injuries. Obviously, the meniscus, especially on the lateral side, when there is depression, the meniscus can incarcerate in the fracture, and you have to know the geometry of the fracture. If there is associated meniscal tears, they need to be dealt at the same time as you deal with the fractures. One of the part of the joint, the medial tibiofemoral joint, is very important, because if there is incongruity in the medial side of the tibiofemoral joint, then obviously it will lead to varus deformity, and that can lead to early arthritis of the medial compartment. So you have to have good plan to treat these medial sided injuries as well. Also to note that these are unstable injuries, and sometimes that can be associated with lots of soft tissue injuries, including neurovascular injuries. So it's quite important to know about the anatomy of the nerves and the vessels around this corridor. Obviously, we'll go through the corridors in more details when we go through the different fracture patterns. Moreover, the slope, the proximal tibial slope, is different in males and females. So when you recreate or reconstruct the proximal tibia, you need to be aware of that. The medial tibial condyle has got a different slope than lateral tibial condyle as well. So all these factors should be taken into account when you start treating these kind of injuries. Obviously, you know the lateral tibial plateau is convex and is higher than the medial side, which is concave. Anterior compartment muscles are attached to the anterolateral tibia. So when you do an anterolateral approach, you need to be aware of what muscles you need to be approaching when you do anterolateral approach. The pes anserinous structures, which include the tendons on the anteromedial side of the tibia, have to be managed as well if you're going to do a medial posteromedial approach. And how to preserve this pes anserinous is also important. So if you know the structures attached to the proximal parts of the tibia, that also helps in determining how to approach these kind of injuries. And there are challenges, if you do a posteromedial approach to a proximal tibia, you will come across the tendons. In my practice, I usually preserve them, but if it's coming in the way, and if you feel that no, you need to go behind the tibia quite proximally, then you may have to sacrifice them. As you know, the forces acting on the proximal tibia are different medially compared to the laterally. The medial side, the forces, the body weight, 60% of the body weight will pass to the medial compartment compared to the 40% on the lateral compartment of the knee joint. These kind of injuries have bimodal distributions. So younger patients will have high energy trauma, especially road traffic accidents. And they have got comminuted unstable proximal tibial fractures. Whereas if you look at the elderly population, they have got low velocity trauma. They can injure in a simple valgus injuries, which can lead to compression of the lateral tibial plateau. So those kind of bimodal distribution is seen in most of the countries. Depending on the fracture location, the lateral side is more commonly affected than the bicondylar variety, and the bicondylar fractures are more common than the isolated medial condyle fracture. The location of the fracture depends on the position of the knee when you have the injury. So the knee could be in flexion, extension, valgus, varus, and when the axial load happens, during the injury, as the axial load goes through the tibial plateau, depending on the position of the knee, the tibial plateau fractures. And not only the bone fractures, but there is soft tissue injury. So, if it's a valgus type of injury, you will have a lateral tibial plateau fracture, although you will also have to assess the medial sided structure. So there could be injury to the MCL or the medial meniscus as well. So those things have to be considered at the time of treating these kind of injuries. Ligament avulsions are quite common, and capsular avulsions are also common. So you can have peripheral injuries to the tibial plateau, which could be either avulsion type or compression type. So they're called rim compression and rim avulsion fractures. And these are indicative of high energy trauma. They are unstable injuries, and you need to look out for that. You can have avulsion fractures of the ACLs and the PCL, and these can be considered accordingly to treat these kind of injuries. Obviously, you have to look out for vascular injury and neurological injury with these kind of high energy trauma fractures. Joseph classified proximal tibial fractures, the tibial plateau fractures in AP views of X-rays, and you all know the classification. Basically, in type 1, it's a split fracture. In type 2, it's a split depression fracture. Type 3 are just depression, there is no split. So they are 0 column fractures. That's what we call them nowadays. Type 4 are the medial tibial plateau fractures. Type 5 are bicondylar with intact metaphyseal diaphyseal continuity, whereas type 6 are bicondylar, but with dissociated metaphyseal diaphyseal continuity. So type 4, 5, and 6 are high energy injuries. They are quite unstable, and you have to look out for other injuries. They can be classified as tibiofemoral dislocation injuries as well, because these injuries are associated with lots of soft tissue injury, including ligamentous and ligamentous injury, which can lead to subluxation of the knee joint. Not to forget Holland-Moore classification, which was before the Schatzker classification. Specifically to note the type 1 split injury. These are posteromedial injuries. They are shear injuries. They go vertical in direction, and these have to be addressed because this can lead to instability of the medial compartment and cause quite a few problems. These have to be approached in a certain way, and we will talk about it in the next few slides. Also to note the type 3 and type 4, these are rim fractures, the one fractures that I just talked about in the few previous slides. So type 3 is the avulsion rim fractures. These are capsular avulsion injuries. And type 4 are the rim compression fractures, and these are unstable injuries. The classic example of type 3 injuries of Holland-Moore are the Sigon fractures. Cheng-Fun Liu classified further with this is the CT-based classification, and this is more commonly used nowadays because you got the 3-dimensional view, so that you can know what kind of corridors you need to approach when treating this fracture. So Dr. Liu classified proximal tibial fractures into 3 columns. One is the medial column, one is the lateral column, one is the posterior column. So you can actually divide the whole proximal tibial plateau in 2 halves, and then divide into anterior and posterior, and then divide the anterior part into medial and lateral. Cheng again divided the posterior parts into posteromedial and posterolateral as well. So depending on which part of the tibial plateau is affected in the axial views of CT scans, you can then approach these kind of fractures more logically. And this is what we are going to talk about. Many classifications have come after this, and they have subdivided into various kind of zones of the proximal tibial plateau, but we'll just, to be simple, we'll just follow Dr. Liu's classification of CT-based corridor or column injuries. How do you assess the patients? You always go, because these are high velocity injuries, you always talk about ATLS protocol, make sure ABCs are all stabilized, and then concentrate on the limb. In the limb examination, make sure it's an isolated injury, make sure there is no compartment syndrome, make sure of the neurovascular status of the limb, and also comment on whether it's closed or open fracture. So that's what the examiners will expect you in the exam. So once you determine it's an isolated injury without compartment syndrome, without distal neurovascular deficit, also comment of the soft tissue injury, bruising, yeah, ecchymosis, swelling, that determines how you're going to approach these injuries. History is important. How did the injury occur? What was the position of the knee when this happened? Was it a simple injury? Was it a twisting injury? Was it just a low velocity? Was it high velocity? Was it fall from height? If there was fall from height, look for other injuries as well. And examination, we have been through that. So inspection, palpation, looking for compartment syndrome, testing for the neurovascular deficit, especially the peroneal nerve, injuries which can lead to foot drop and reduce sensation in the first web space. Vascular assessment can be done by Doppler. Also, you can do a ABPI measurements to make sure there is no vascular injury. ABPI more than 0.9 ensures that there is no vascular injury. X-rays are, you will have varieties of X-rays going from simple, subtle injuries like the AP view here, which shows the fracture pattern, but there is no kind of displacement. And this is what you may have to think when you are answering in the exam. And on the lateral view, you can see there is fractures, especially in the lateral views. You can get a cortical depression, which can be seen in the true lateral views, and you can determine whether it's a medial or lateral kind of injury. So if it's a shear fracture of the posterior part of the tibia, then it's possibly the posteromedial side that has sheared off. If there is a depression on the concavity of the tibial plateau, then obviously it's a depression kind of fracture. And these X-rays are bound, so there's a lateral tibial plateau fracture, along with the depression of the articular surface, along with the proximal fibular fracture. So these are the things that you will have to talk about when you're answering in the exams. Also comment of the femoral tibial subluxation, especially associated with these kind of injuries. A CT scan nowadays is an essential investigation in tibial plateau fractures, and this will give you more information as to the geometry of the fracture and how you're going to approach the fracture and how you're going to treat it. The 3D reconstructions are quite helpful in determining what kind of geometry it is, especially to look for the apex of the fracture, so that you can put something to buttress the fracture just where the apex of the fracture ends. See, these are the slices of the scans that can be put in the exams scenarios as well. So in the coronal sections, you have to determine how much depression there is, especially on the lateral side, by comparing it from the medial side. To know that we know that the lateral side is convex, so the height of the lateral side is slightly higher than the medial side. So depression, when you measure from the medial tibial plateau, is much more than what it seems, and that has to be taken into account when you go in and reduce this compression and the depression. Axial slices are quite important because that's going to tell you whether it's what corridor is involved. So if it's, in this case, it's the anterolateral corridor that is involved, and hence you'll be approaching this through an anterolateral approach. And this is what we are going to talk about as to how we are going to determine our treatment based on the geometry of the fracture. So these are the corridors. You can draw these corridors on the CT scan axial slices, and this is neatly drawn. So you can see that there is a posteromedial fracture. And this fracture can easily be approached by a posteromedial approach so that we can fix it for this patient. And that is the importance of having a CT scan. These are different examples of different corridors, how to determine what column injury this is, and hence we can determine how to approach these columns using various kind of approaches, which we'll be talking about in a minute. So in the first example, it's anterolateral as well as posterolateral injury. This can be approached by an anterolateral approach. You can either extend it to the posterolateral side using a Forsch approach, or you can use the suprafibular space to get into the posterolateral column. In this, it's an anteromedial part of the proximal tibia that is involved, and hence you'll be using an anteromedial approach to approach these kind of fractures. And you can have multiple column injuries, and you will have to think hard as to how you're going to approach it. And we'll talk about it as well. So the first thing to do is to draw an equator in the proximal tibia. Yeah, when you see axial slices in the CT scan, you draw a line to divide it to anterior and a posterior part. The anterolateral injuries can be approached by an anterolateral approach. And then you can fix it using the standard techniques. You can elevate the depression, put some draft screws, put bone grafts, and then buttress it with a plate. And that will be a stable, that will stabilize this kind of injuries. So determining the personality of the fracture is quite important. As you can see in this example, the posteromedial part of the tibial plateau is involved in this, and hence you will be approaching this with a posteromedial approach so that you can fix it back into place. And with the 3D scans, you will know where exactly is the apex of this fracture. You reduce the apex of the fracture rather than doing the intra-articular reduction. You do extra-articular reduction and then fix it with a buttress plate. And now in this example, you can see it's involving the anterolateral and the posterolateral corridor of the column. And in this case, you will have to think hard as to how to approach both these columns through the approach that you want. The easiest approach that you can use in this kind of injury is the Forsch approach, where you can go from the anterolateral to posterolateral using that approach, and you can fix both of these columns through one incision. And there are other approaches described for these kind of injuries. You can use Lobenhofer's approach, where you go and do osteotomy of the proximal fibula and elevate it so that you are on the posterolateral part of the proximal tibia. So various kind of injuries will require various kind of approaches. These are multi-column injuries. So you can see in this example, there is an anterolateral column is involved, the posterolateral column is involved, and the posteromedial column is involved. So you have to think hard how you're going to approach it. The posteromedial can be easily assessed, accessed by the posteromedial approach, where you can identify the pes tendons, retract them, and just go through beneath the medial head of the gastrocnemius to approach this fracture. Whereas on the anterolateral and the posterolateral side, you can either use a Forsch approach to get into both the columns, or you could use the anterolateral approach and use the suprafibular space to go into the posterolateral part of the proximal tibia. This is basic biomechanics. So if on the compression side, you have to have a buttress plate. So if there is a posteromedial shear fracture, which needs to be buttressed. So no point in putting a locking plate on the posteromedial side. You have to have a buttress plate to support it so that it doesn't fall away later on. Same way, a supporting plate has to be put on the tension side, and that determines which kind of plate you're going to use on the medial or the lateral side. And this shows exactly what we do. So the shear fracture of the posteromedial side, you go from a posteromedial approach the apex of this fracture, which typically reduces in extension, and then put it back in place and put a buttress plate. And that will be a stable fracture and stable configuration for you. This is the anterolateral side of the tibia, and these are the structures that you will be encountering on the anterolateral side. So when you do an anterolateral approach, you will have to look for the iliotibial band. So when you approach from the anterolateral side, you go through the iliotibial band, and then between the iliotibial band and the capsule, you will have to dissect further to get into the submeniscal space, and then lift off the meniscus through the coronary ligament, and then approach the joint from the anterolateral side. And you can see there is a space just above the tip of the fibula, which can give you access to the posterolateral side of the tibia. You have to be careful with the lateral collateral ligament when you approach the posterolateral side of the proximal tibia using a suprafibular approach. And that's the Forsch approach, the posterolateral approach, which you can go from the anterolateral side into the posterolateral part without sacrificing the fibula. If you feel that it's much more difficult, you can do an osteotomy of the proximal fibula, lift the fibula up, and you can approach the posterolateral side of the fibula with that kind of approach as well. The posteromedial approach is the classic approach where you go to the posteromedial side. You can do it with semi-recumbent position. You don't have to have the patient prone. The advantage of semi-prone would be that if you have an anterolateral injury, you can then approach at the same time rather than flipping the patient over. So the treatment principles is to obtain and maintain the anatomical articular reduction. It's quite important because these patients have got significant injury. Any compromise with anatomic articular reduction is going to cause them problems, range of movements, or subsequent arthritis in near future. Reduction of the condyle width. Because of the split injury, the condyles split up and the condylar width increases. So one of the treatment principles is to reduce the condylar width to get the anatomic back in position. You have to address the meniscal injuries. So if you see a meniscal injury at the same time, it's difficult if there is a medial sided meniscal injury, because access to the medial meniscus is quite difficult with open approaches. Restore the mechanical access. It's quite important because if it's in varus, that will lead to arthritis and instability. Same with the lateral side. So if you haven't reduced the articular depression, it can lead to valgus and lead to instability, giving way sensations. So restoration of mechanical access is quite important. You need to have a stable fixation, and the key is the early range of movement. So if you have a stable fixation, you can get early range of movements so that they can achieve a good range of movements post-operatively. So going through the treatment options, so zero column is basically just depression. This can be treated without opening up the fracture. You can just use X-ray guided TEMS and reduce the fracture, put some bone graft, and you can do it arthroscopically as well. If it's a single column, especially the anterolateral, you go through the anterolateral approach. You elevate the depressed fragments. The depressed fragments is usually on the medial side of the injury. So you go there, you elevate the fracture, you put bone grafts in it, and then put a nice buttress place. You can put raft screws as well, which are subcortical screws that helps into stabilizing the depressed fragments so that they don't depress further when the patient starts bed bearing. If it's a bicolumnar fracture, you can go either side. If it's anterolateral, posterolateral, you go from one side. If it's anterolateral and posterolateral, do incisions and reduce and treat the fracture. In multicolumn injuries, you can have multiple approaches. You have to take care of the soft tissues because it's quite important not to devascularize the fragments, which can lead to further problems. So always be careful, always respect the soft tissues when you dissect in multiple column injuries. And you have to talk to the patient. These are devastating injuries. You have to tell them about pain, the swelling they are going to have after the surgery. You have to manage their expectations because this is a life-changing event. Patients are going to have some kind of restrictions even after the surgical treatment. Walking, driving may be affected. You have to talk about the complications of these kind of injuries and the work implications, as well as future aspirations might change. They may require further surgeries in future for either realignment surgeries or replacement surgeries because of the future arthritis that they could get. Smoking, you have to counsel them to stop smoking. And in elderly patients, you can opt for non-operative management. In summary, tibial plateau fractures are life-changing injuries. The treatment is based on the injury pattern and the geometry of the fracture, as well as stability. And there is a concept of columns that we should be understanding so that we can treat these injuries quite effectively. Thank you.
Thank you, Dr. Joshi, for that brilliant lecture. You've covered almost everything on tibial plateau fractures. There are a couple of questions. One is, how do you approach a posterior shear fracture? For example, when you have a primary involvement of the posteromedial and the posterolateral column, do you approach it through a midline incision, or do you go from posteromedial and go right to the posterolateral column?
The anterior incisions nowadays are gone out of favor. So I personally would go with posteromedial approach, and you can actually feel from the posteromedial side the posterolateral column. So you can actually put a T plate which can cover the posteromedial and posterolateral side through the posteromedial approach itself.
Okay. And how often do you do a osteotomy, fibular osteotomy? Have you encountered that scenario often?
I have done a few, especially if the fracture, the apex of the fracture goes just behind the fibula, and the fibula is always in the way. And in that case, it's better to do an osteotomy of the fibula, lift the posterolateral corner structures, and then approach the tibia from that side. It's very uncommon. Usually, you can get away with a suprafibular approach, or you can do a Forsch approach and approach the posterolateral aspect of the tibia.
Okay, and once you do the fibula osteotomy, what kind of implant are you going to place there?
You put a small neutralizing plate. It doesn't need to be a fancy plate or anything.
Okay, so the question is, do we have enough space? Because the fibula is always going to be there. Do we have space enough to put a plate, or you just put screws and stabilize that area?
It all depends really. So if it's a big fragment, so if it's just a neck of the fibula, you are going to have a difficulty in putting a plate because there's this nerve which runs just at the neck of the fibula. In that case, you can just put a screw with a washer and go bicortical, or even you can go unicortical in these kind of injury and put the screws into the canal, because these canals are quite small, so you can have a good purchase of the screw into the canal, and that's a very good fixation. It hasn't it all depends on what where the osteotomy you're doing. So if it's going to be osteotomy quite distally, then obviously you can put a plate on. But if it's just at the neck or just below the neck of the fibula, then obviously you can put a small 3.5 screw with a washer.
Okay, thank you for that. The other question is, what is your classical way to address a bicondylar fracture? Do you go a combined anterolateral approach with a posteromedial approach, or?
Yeah, that's the standard. That's the standard. So most of the injuries that you will get is anterolateral injuries, compression, depression, fragment with a split, with a posteromedial shear injuries. And a long time ago, you used to do dual plating for these kind of injuries with one anterior incision, but that led to quite a lot of bone problems and devascularizing the structures. So most of the time nowadays, most of the knee surgeons will be doing a dual incision technique, where you will go posteromedially, buttress the posteromedial fragment, and then go anterolaterally. And because the first thing you need to understand is the medial side has to be reconstructed so that the lateral side can go on to the medial side. So always try and do the posteromedial side first. Put a buttress plate, get the medial column intact, and then go anterolaterally, and then build up the lateral side to the medial side.
And how do you address defects? For example, what is the bone graft substitute that you commonly use?
I use the calcium sulfate or tricalcium phosphate. You can get putties where you can just inject them into the defects, and that works really well. And there is lots of research going on, and everybody feels the calcium phosphate, that tricalcium phosphate
Is
putties.
the injectable one or the blocks?
No, injectable. So you can inject it.
Injectable ones.
Yeah, so the defect is filled up with the injectable one, and you can pass screws through it. So it's not a big, once it's all sets up, you can just put a plate over it.
Okay, so do you think there's a role for an autologous graft along with it? I mean, do you use it, your autogenous ilia crust? Do you harvest anytime?
Not really, because that causes the harvest site morbidity. So in my practice, I tend to use calcium phosphate quite. That's been my standard practice. You can use
that is injectable calcium phosphate cement, right?
That's correct, yeah. And they are absorbable. So in 2 years' time, you won't see it. So it self-absorbs and replaced by the normal bony architecture.
Okay. And any experience with variable angle locking plates? I think that's just a fancy, and I mean, depends on the scenario, right?
Yeah, so posteromedial side, as I said, it's a compression side, so you just need a buttress plate. So that works really well. On the anterolateral side, you can have a locking plate, a variable angle locking plate, a simple buttress plate. It all depends on your philosophy. So even if you put a locking plate, the first screw you're going to put in is the oblong hole in a buttress mode. So essentially, you're converting the anterolateral plate, the locking plate, into a buttress plate to start with. And then obviously you can fire a locking screws through it, which has got better purchase, I must agree. And it also locks into, especially in osteoporotic fractures, that can have a role. So yeah, I do use anterolateral plates, usually are locking, but the first screw you do is the oblong hole so that they act as a buttress to start with. At the same time, if there is a depressed fragment which you have elevated, you always put 1 or 2 raft screws so that the depressed fragment stays in place.
And do you prefer a 3.5 system or a 4.5 system on the anterolateral side?
The 3.5 is quite low profile, so I like it. It gives enough stability on the anterolateral side. So 3.5 are much better than 4.5. The 4.5 are quite bulky, and they do cause anterolateral irritation, especially on the iliotibial band. And that leads to quite a lot of implant problems, and you have to go back and take the implants out. But 3.5 works well. It's quite low profile, and I do like it.
And on the posteromedial side, what implant do you prefer?
Yeah, so posteromedial side, you can get custom plates. So they are available. Posteromedial plates are available, so you can use those. Or you can use simple 1/3 tubular plates as well. All you need to do is find the apex of the posteromedial side, reduce the apex, and put a plate in a buttress mode. So it could be just a semitubular plate or a T plate, whichever you fancy. It all depends on how much exposure you have done as well. So if you've got a very small exposure to reduce the fracture, then obviously you don't have much choice but to put a semitubular plate just to buttress it.
And the other one is, how do you approach a PCL avulsion fracture? What is the approach that you prefer?
These avulsion fractures, I tend to leave it and do a delayed reconstructions. So I let it heal, and you create the whole platform in the first instance. And once you have got the bone platform back, then you can address the ligamentous injuries, especially the ACL and PCL. Direct reconstruction at the time of fracture fixation is probably not the best idea.
What about if you have an isolated PCL avulsion? How do you approach it?
Yeah, so if it's an isolated PCL avulsion, you have got a couple of techniques. You can you can do it arthroscopy. Some people, if it's a small avulsion fracture of the PCL, then you can loop it around the PCL fracture through the same kind of tunnels, tibial tunnel, and then you can pull it out and just knot it outside using a endo button or tightrope button, whichever you feel comfortable with. Or you can approach a posterior approach. So you can go posteromedially and lift the whole posterior side up. You can even reduce this intra-articularly, but most of the PCL avulsion fractures are extra-articular. So you can approach it from the posteromedial approach and put a screw in there, or if it's a big, then you can put a small plate.
Do you think a posteromedial approach is better than a midline approach for a PCL avulsion fracture?
Yes, I think you posterior approach, but you have to dissect everything. Both of them have been tried and tested, but the new in this era, posteromedial approach is enough. You do a hockey stick on the crease of the posterior knee, posterior part of the knee, and just extend it on the posteromedial side. Lift the gastroc up, and it's quite approachable, the posterior part of the knee.
No, my question is, do you want to go between the heads of the gastrocnemius, or you lift the medial head and go from below?
No, you lift the medial head and go from below.
Okay, so
accessible.
So you feel that that's a better approach for PCL avulsion rather than going between the heads.
Yeah. So what you need is a good exposure. So if you're comfortable with a posteromedial approach to have a good exposure of the posterior part of the knee, then you find most of the time you can approach the avulsion fracture through a posteromedial side. So I haven't felt a need to go posteriorly between the two heads of the gastroc to approach that kind of injury.
Okay, no, the only concern was like someone to angle it, because you need to go dead anteriorly. So when you're going from midline, it's easy. The direction is going to be easier.
Yeah.
Posteromedially, I mean, you need to reflect a bit more towards the
lateral. So you can even once you reflect, you can dissect it beneath the popliteus tendon and go all the way to the posterolateral side. So it is possible to approach even the posterolateral side from the posteromedial approach. So obviously it will cause soft tissue trauma, but if you're careful and gentle enough, it is possible. And that's my experience. So I haven't.
True. Even I've listened to Kongfen Lo actually. So he's also a big advocate of the posteromedial approach. I remember him saying very clearly that you can go for the posterolateral area through the posteromedial approach. A significant the posterolateral area can be addressed through the posteromedial approach. Am I right?
That is absolutely correct.
Okay. And how do you implement the Lowe's classification in your clinical practice? How do you really go about while you plan for surgery?
So the Lowe's classification is quite good because you know where to approach the injury. So if you know how to approach and have the good exposure, then you can treat any kind of injuries. So that is the main whole idea of this column theory, or to determine what kind of approach you can use to treat specific injuries. So before this classification, we used to treat it as whole proximal tibia. So it was like a one column, and you go in, you fix everything through one incision and sort it out. So that was the whole idea, and that caused lots of soft tissue injuries, lots of wound problems. It was like a bone sandwich, and it wasn't there were lots of complications. So after this concept of columns came, you then approach the whole columns with different approaches, and that helped with soft tissues. So there is less soft tissue trauma, and hence there is no wound problems. There will be wound problems, but not as much as if you go like a single column treatment algorithm. So that's the whole idea of dividing the whole proximal tibia into different columns, so that you can treat each column differently, rather than treating the whole proximal tibia as a one column.
Okay, and the other one is in one of your slides, actually, there is a line that you have shown that runs anterior to the fibula in the coronal plane. What exactly do you convey with that?
Yeah. So it was in 2018, I think Schatzker's team published this paper where they found the equator of the proximal tibia. So that starts from the anterior part of the fibula to the posterior part of the superficial MCL. So that's the imaginary equator that you draw to determine, whether it's anterolateral or posteromedial kind of thing. And it's practical because when you go from the posteromedial side, you always encounter the superficial MCL, and you need to know whether to go anterior to the superficial MCL or posterior to the superficial MCL. And that is very helpful, that kind of equator, to determine where you are going to. So if you're going to go anterior to the superficial MCL, there is no point in doing a posteromedial approach because you can't cut the superficial MCL, you see. So you have to go anteromedial. But if the fracture is behind the superficial MCL, then you go posteromedially. That's a good concept. Similarly, on the anterolateral side, if the fracture line is anterior to the anterior margin of the tibia, fibula, then you can go with the anterolateral approach. But if it's posterior to the anterior part of the fibula, it's going to be very difficult for you to approach that fracture with the anterolateral approach. So that's kind of a equator which you then think about which approach you can do to fix that kind of column.
Okay, thank you. Because the equator concept is it's very interesting to note. And I think it's a revolutionary concept, even though Schatzker described the classification decades ago. I mean, the equator concept is only late. I mean, it's just come out recently, 2 years ago, right?
Yeah, that's correct.
And do you think because there is so much of emphasis happening on the Lewis three-column concept, do you think that the Schatzker classification is obsolete today?
It was published in 1979, if I'm not wrong. So it's been there for a long time. I disregard Schatzker's classification. I just feel that, the way things are moving and the way the concepts are changing, obviously we are doing more and more CT scans for these injuries. So the concept of Schatzker's was before the advent of the CT scan. So as we move forwards, there will be further classification systems that can come. It doesn't mean that we should forget what was there before. So I don't think we should disregard Schatzker's classification as of yet.
True, because there is a view that Schatzker looks at the coronal plane, right?
Exactly.
Looks at the coronal plane, and the Luo's classification looks at the axial plane. So it is totally different. So it is very important, like you said, that the Schatzker is very important. The X-rays are important, and overall alignment is going to be obtained only by the Schatzker classification. And so you need to have a combined approach. You need to look at Schatzker and the Luo. And what is interesting is if someone looks at the sagittal plane, there's a new classification that's going to come out.
Yeah, you never know.
Okay. Thank you, Dr. Joshi, for your enlightening talk. And it was very nice to listen to you. And I think all of our readers are going to really benefit from your wonderful lecture. And thank you once again for joining us. We look forward for more from your side.
Thank you so much. Thank you. Thank you for